Good afternoon, everybody. I'm Dr. Tejinder Singh. I'm working as a senior consultant hematopathology at Onquest Lab, Gurgaon. It is my proud privilege to welcome you all to the first webinar organized by Onquest Laboratories this year. That is update on minimal residual disease in pediatric leukemias. We have three stalwarts who are well versed and have been reporting minimal residual disease in pediatric leukemias. We all know now MRD is the major prognostic factor in acute leukemia, especially in ALL. And here today we have three speakers, and these are Dr. Sirisha Rani, Dr. Shivali Ahlawat, and Dr. Pooja. So we'll be starting the program with Dr. Sirisha Rani, and her topic is MRD-based risk stratification and treatment in pediatric leukemias. Over to you, Dr. Sirisha.
Thank you very much for kind introduction, sir. And thank you, Onquest, for inviting me as a speaker. So we all know, can you please share my slides? Yeah. So we all know, how the scenario of pediatric malignancies have changed in last 3 decades, like compared to what it was earlier and then what it is now. So there is a phenomenal improvement in the success in terms of achieving long-term remissions and long-term success in these children. If you look at, for example, acute lymphoblastic leukemia 3 decades ago in 1970s, if we take it 4 decades ago, the results were like less than 20%. But now currently, even in India, in also in other developing countries, with good supportive care in terms of safe blood products, good antibiotics, infection control, and nutrition care, especially in children, the results are like, up to 85%, 90% at par with the Western countries. So, and all this has happened with the advent of modern chemotherapy and better understanding of risk stratification based on genetics and MRD. Just moving on to the topic, acute lymphoblastic leukemia. Next slide, please. Acute lymphoblastic leukemia is most common pediatric malignancy. We know global incidence of cancer is rising, and then more than 3 lakh children currently less than 15 years are adding on to the pool, and in that 5 to 6 per lakh is the incidence of acute lymphoblastic leukemia in children less than 15 years. And the cure rate we have just discussed, they are phenomenally improving compared to earlier. However, there is a small percentage of cases where relapse and toxicity remains as a matter of concern. So next slide, please. So before I talk about MRD,
ma'am, you will have to unmute yourself.
Oh, sorry. I spoke few things. You haven't heard anything from me?
No, ma'am, we heard you. You just went on mute, ma'am.
Okay.
Yes.
Right. So just before going on to MRD discussion, a little bit about the basics. This is the classical presentation of your acute lymphoblastic leukemia, where we see child present with fevers, lymphadenopathy, organomegaly, bleeding manifestations, and typically high count with low platelets and low hemoglobin, along with peripheral smears showing blasts and all. So with here the case scenario is like T-cell ALL. Next slide, please. On the other hand, you also, other than classical manifestations, what I just said, you also have atypical presentations, like child may present just with joint pains or limb pains, and then they get at times get treated like a juvenile rheumatoid arthritis or juvenile idiopathic arthritis, what you call it now, as for some time by pediatricians, and then they can go on receiving steroids for some time, and then they can get high risk over a period of time. So that is one of the atypical presentation what all of us should be aware, so that we can prevent them from becoming high risk. And other than that, like, they may present just with isolated anemia. We have few cases where they have presented with very severe anemia with normocytic, normochromic picture with normal WBC, normal platelet count and all. And or they may present just with isolated thrombocytopenia or just isolated lymphadenopathy. We have seen few cases where kids got retroauricular nodes, where pediatrician got alerted for the lymphadenopathy because there was no local infection, but still they had lymph nodes in the retroauricular area, and it prompted them for doing the workup, and then they picked up and isolated bleeding manifestations or isolated thrombocytopenia kind of picture. These are atypical manifestations. Next slide, please. So before we go into the MRD, like when to do, what are the indications, and based on the protocol, when do we do, and time points and all. If we look at the treatment, like you divide the treatment into supportive care and definitive care. In the definitive care, for ALLs, as we know, it is mainly chemotherapy based, and every institute has their own preference in choosing the protocol. Next slide, please. So coming to MRD, what is MRD? So it's a minimal residual disease where you see small number of leukemic cells that remain in the patient during treatment or after treatment when the patient is in remission. So patient will not have any clinical symptoms, or morphologically there will be like, normal counts will be normal, but still there will be a minimal residual disease which has a very good prognostic implications. So if you look at, like, when was this first described? In 1980s itself, the first MRD paper goes back into 1980s on T-cell ALL. However, if you look at the historic data, so initially combination chemotherapy, later we have gone into the cytogenetic based risk stratification, and then in 1980s MRD based risk stratification has started. In 1990s, the extensive studies have definitely increased, and then they have identified that doing the MRD in first 2-3 months is more beneficial in risk stratification. So initially, why T cell, why not B cell? We know that it is difficult in B cell, as you need a multicolor flow compared to T cell. So that's the reason it was first described in T cell. Of course, Dr. Shivali speak more details about the techniques and methods. So there are different techniques that we can follow, like cytogenetics, flow cytometry, PCR based, and all these are aimed at detecting, quantifying residual tumor cells beyond the sensitivity of your cytomorphology. Next slide, please. So as we all know, like in morphology, you count 1 in 100. Whereas in MRD, you count 1 in 10,000 or 1 in a lakh, depending on the method you are choosing, whether it is a flow cytometry or genetics, the PCR based technique, what you are doing, it depends on the sensitivity, your log varies. So MRD assessment during various time points of ALL treatment aids in different risk stratification, whether you want to augment the treatment or you want to cut down the treatment and categorize them into low risk, so that you can cut down on the long-term toxicity. So it has very high prognostic importance and highly effective in risk stratification, which is well established, we all know. And of course, in developing countries like us, still we need to catch up. Most of the centers now, good number of centers are doing, but not all centers are doing MRD. Next slide, please. So what are the methods of doing MRD? As we just spoke, like, one is by phenotyping, and karyotype or fish markers are helpful if you have a initial markers that are abnormal. And next level is like doing the PCR by 2 techniques. All these techniques will be, Dr. Shivali will be expanding on all these techniques. Next slide, please. So you have different sensitivities and advantages and disadvantages of these methods. But in India, we all depend on flow cytometry right now, as the PCR is more expensive and laborious. So we depend on flow cytometry most of the times. Next slide, please. So how do we interpret MRD? So MRD, you divide them. If you divide them, one is the complete MRD response, where at a given time point you are doing MRD, and then there is no detected disease at that time point, you call it as complete MRD response. MRD persistence is like, you have a ongoing MRD positivity. It may be like, falling MRD, but still like, it's an ongoing positive, which is called as MRD persistence. MRD reappearance is like, you are initially MRD negative, but again, later at some point, you are becoming MRD positive. It may be in chemotherapy patient or it may be in a transplant patient. But if it is reappearing, it is a reappearance of MRD. Next slide, please. And how do we decide whether you go for peripheral blood or bone marrow for MRD? So the scenario is different between B versus T. In T cell, if you compare peripheral blood versus bone marrow when you are performing MRD, the log difference is 1 or almost same. Whereas in B cell, the log difference is 1 to 3. That is the reason in B cell, definitely you have to depend on bone marrow for MRD assessment, whereas in T cell, you can even go for peripheral blood. But having said that, none of us do that as a routine practice. Most of us, like in our center, we always do bone marrow to assess the MRD because you don't even want that 1 log difference. Next slide, please. So what are the time points of doing MRD? There are, as I initially mentioned, the MRD assessment when to do, like why we are doing in the first 3 months is based on the studies that are published in 1990s, like between 1990 to 2000. There are a good number of studies which says that MRD assessment in first 3 months is most effective way of assessing the disease. So risk stratification on based on BFM protocols, MRD assessment is suggested at 2 time points. One is post-induction and post-consolidation. Based on that, you decide like MRD low risk is at both the time points, you should be MRD negative, that is low risk. Whereas at week 12, if you are MRD positive by more than 0.1, you will be categorized in high risk MRD, and then you have to augment the treatment protocol, and most likely you have to go for stem cell transplantation in those children. Dr. Pooja will be talking about HSCT based on the MRD in the talk. Next slide, please. So MRD assessment time points in BFM, we have seen end of induction and end of consolidation, which is also same in UCAL. So in UCAL 2003 trial also clearly demonstrate that based on the MRD, one can reduce the treatment intensity in the low risk patients and augment the treatment in MRD high risk patients. In UCAL 2011, MRD measurement is suggested on day 29 and week 9. So in BFM week 12, but depending on when you finish the consolidation, so whether it is week 9 or 12, it is almost same. So next slide, please. Whereas in COG, so in COG, they do MRD either in peripheral blood on day 8 or even in peripheral blood on day 15, week 2, day 14, or MRD even on day 29 has been incorporated in COG protocols. However, the more sensitive one is like, day 29 compared to doing early MRD. But however, if you do early MRD, what COG protocol says is like you can pick up the high risk group early. So, but on the other hand, the risk stratification is mainly done based on the day 29 MRD. So the following study, one of the study published by Van Dozen et al. It's an old study, but good study which says the importance of MRD. Like in low risk patients, relapse rate is very low, like 2%. Whereas in high risk patients, the relapse rate is significantly high. So which indicates the because as this is old study in those days, like based on the MRD, stem cell transplantation was not that aggressive in the 2 decades ago. So the relapse rate was quite high. That is how you see the high relapse rate in those MRD positive patients. Next slide, please. MRD HSCT, Dr. Pooja will be speaking about that in following talk. But just to brief you about MRD in HSCT, it's also in relapsed AL patients and in patients undergoing stem cell transplantation. MRD measurement is mandatory, and it is a good indicator when to transplant the child, because only when they become high risk cases, when they become MRD negative, you are supposed to transplant, that is to improve the outcomes. And of course, post transplantation also one will monitor the MRD. Based on that, there are several things that will get decided about giving the DLIs and all the other things. It's a good predictor to maintain the graft or protect the graft. Based on the MRD, you decide the further treatment. Next slide, please. So we have done study on MRD. Our MRD, most of the MRDs are done in OnQuest. Our data, just to tell you in brief about our data. Next slide, please. So we included between 2015 to 2020, 203, over a period of 5 years, 4.5 years, 203 children were included who were ALL. Next slide. So predominantly, as we all can guess, it is BALL, and a small percentage, like 20% of them are TALLs. Next slide, 10%, sorry. So, and high count disease was seen only in 26% of the cases. Next slide, please. So we had cytogenetic positivity, structural problems were seen in 30% of cases, 28-30% of cases, where the common one was noticed to be EDV6 TANX1. Next slide, please. So this is a karyotype profile of our patients, where hyperdiploidy was seen in almost 15 to 16% of cases, and then majority of them, like 70-75% of them, had a normal karyotype. Next slide, please. In our series, on day 33, around 10% had positive MRD. So for all of those children, and those 21 children who had high-risk MRD, only in cases where cytogenetics were high risk, or where they had high count, we augment, sorry, not high count, prednisone poor response. So where they had high-risk genetics or PPR with high-risk MRD, we augmented the treatment for them with HR blocks. We follow BFM protocol, so we augmented the treatment with HR blocks. And whereas remaining children who had other standard risk factors but only MRD positive, in them we continued the regular augmented BFM consolidation, and then with that, majority of them cleared the MRD, cleared the disease, and became MRD negative at the end of consolidation. Only 2 of them out of 21, only 2 had persistent MRD, and then out of those 2, 1 went for transplant, 1 didn't consent for the further treatment. Next slide, please. So this indicates that overall survival with minimum follow-up of 1 year in our series with a range of 1 to 5 years. The overall survival was 87.2%. Relapse rate was 9.2%, which goes hand in hand with the historic data. Next slide, please. So based on the MRD-based approach, like if we segregate them and in MRD, what happened to MRD patients and correlation with the relapse and their outcomes, MRD was statistically highly significant in indicating the prognosis in these children. Next slide, please. So in our series, we also saw that, high count children had association with the high MRD positivity. However, high adverse genetics or PPRs or age, so they did not correlate with the MRD positivity. Next slide, please. So this is just a table describing what I just said. Next slide, please. So as we saw in previous slides, MRD is very good indicator for prognostication and risk stratification and deciding on the further treatment. MRD evaluation in bone marrow on day 33 in all cases of AL should be a good practice. We all should make it mandatory to risk stratify them and identifying the early relapse in those cases and augmenting the treatment. So this will further improve the results, and then will achieve better results in going ahead with the ALL management. Thank you.
Thank you, Dr. Sirisha, for such an excellent presentation, and you have made a difficult topic very, very easy. For those who joined late, I may tell you that Dr. Sirisha is working as a hemato-oncologist and bone marrow transplant plantation specialist at Rainbow Hospital, Hyderabad. It was a pleasure listening to you. We'll have discussion and question answers at the end.
Thank you, sir. Okay.
Now I invite Dr. Shivali Ahlawat. She is the Director of National Reference Lab, Oncos Laboratories, Gurugram, Gurgaon. And she has a lot of experience on MRD, especially in acute lymphoblastic leukemias as well as in TALL. And now the Oncos Laboratories has also started doing MRD in cases of AML as well. She will be speaking on current guidelines and approach to flow cytometry MRD in acute leukemias, of course, mainly in children in today's talk. Dr. Shivali Ahlawat.
Thank you very much, sir, for your kind introduction. So the topic has already been explained by sir. If we can just, again have the definition of MRD. Of course, it has been mentioned by Dr. Sirisha also. So the conventional approach to acute leukemia used to be morphological. For CR from the lab's perspective, we used to evaluate the morphological remission. So yes, we can detect up till 1% cells, but since the marrow would be having some normal blasts also, a level of, let's say 5% was taken. So basically what we were saying is that 1 in 20, if you see one abnormal cell in 20 normal cells, above that we used to call it abnormal. Now, of course, this has been refined much further, and that is what we call as the MRD, that is detection of minute levels of residual leukemic cells. It can be 10 to the power -4 to 10 to the power -6 by specialized techniques, which are not identifiable through conventional morphology. So the most common techniques that are used are flow cytometry and PCR, because they are able to reach that level. We can, if we consider karyotyping or cytogenetics, the level of 10 to the power -4 is difficult to reach. So flow, PCR, and of course now NGS is also coming into the picture. Now, this graph is just to show the principle behind MRD analysis. So if we consider two patients who have at the time of diagnosis, let's say a disease burden of 10 to the power 12. So in morphological assessment, we would go up till 10 to the power 10, right? 2 logs. And for MRD, it would go up till 10 to the power -5 or -6. So we have gone till 10 to the power -5 over here. So if you consider patient 1, they both have been started on treatment. This is time point 1, let's say post-induction. So patient 1 and patient 2 both have gone below the limit of morphological assessment, below 1%. But for patient 1, the disease would still be detectable by an MRD technique. Whereas for patient 2, it has gone below the limit of MRD detection also. So responded very well to the initial treatment. Now, this particular patient, if we see, the levels keep going down up till time point 2, let's say post-consolidation, but because those residual leukemic cells are there, eventually they will outgrow and disease relapse is likely to occur unless we go in for intensification of the therapy, or let's say a transplant, something we augment the therapy in some way so that the patient is able to achieve, let's say, MRD negative or a provisional cure for his disease. Compared to that, the patient number 2 already had a very good response to the initial therapy, and the levels continue to go down. So he does not really require that intensification and the associated, toxicities, potential toxicities or side effects that could occur. So this graph kind of just outlines the principle behind why MRD has become such a popular mode for directing therapy nowadays. Now, another thing that keeps coming up in discussions is that, of course, we have multiple criteria for risk stratification, but we do mention, Dr. Sirisha has also mentioned, that MRD is considered an independent risk factor. So you have the TLC, you have the cytogenetics, all those extramedullary disease involvement. So how is MRD different from all of them? That is because MRD, it is a kind of combination of, it is a test which is reflecting two things: the interplay between the tumor cells and the body's response to those tumor cells. So the biological characteristics of the tumor cells, how aggressive are they? And the patient's body, how is the drug metabolized? What is the host response? Based on these, ultimately, we come to know whether those tumor cells are resistant to therapy. If they are resistant, they will persist, and ultimately they will start dividing and lead to relapse. Now, this is just to show the NCCN guidelines. So they do mention that the basic requirement for an MRD technique is the sensitivity should be at least 10 to the power -4, that is 0.01%. The techniques that are mentioned are, of course, Flowcytometry, RQ-PCR, or RT-PCR based on the fusion transcripts, and NGS-based assays. The timing of the MRD, and of course, here again, they have mentioned that for Flowcytometry, the sensitivity is generally expected to be 10 to the power -4, whereas for PCR and NGS, it can go to the power 10 to the power -5 or -6. However, broadly, by and large, the treatment decisions are taken at the 0.01% level. So how much difference this would make is, of course, up to the clinician, that they can get some additional information, but whether they would be adapting their therapy based on that is, it's as per the protocol and as per their clinical decision. The timing of the Mrd assessment, again, it would depend upon the chemotherapy protocol, but what broadly they are saying, of course, upon completion of the induction, end of consolidation, additional time points guided by the regimen used. And again, serial monitoring frequency may be increased in patients with molecular relapse or persistent low-level, persistent MRD burden. And for some techniques, you may require a baseline sample. For example, for flow, it is preferred, but it is not essential. We can manage even without a baseline sample. Another point, important point that is mentioned is that MRD quantification can be affected by bone marrow aplasia. So what happens if you have to do it at the end of induction, but the bone marrow has not recovered? So they do suggest that some of the protocols, they require that count recovery should occur prior to sending the MRD. The other thing that can be done is that if you have sent the MRD during aplasia, but we are able to get very low number of events, so the sensitivity of the assay is affected, then you may need to repeat it after the count recovery. Of course, these decisions are based on the protocol or the regimen that is being followed. So we talk about flow cytometry based MRD analysis. The principle is based on two criteria, that is the LAIP or the leukemia associated immunophenotype and the difference from normal maturation. So by LAIP, we mean that a diagnostic flow is run, certain aberrancies are identified in the blast, and then these particular aberrancies are followed up during therapy. But this is an oversimplified approach. So this was followed in the earlier years of MRD. The problem here occurs is that only those blasts which would show those aberrancies would be considered abnormal. Others would be considered a part of the regenerating normal blasts. Now the problem is that the immunophenotype can change. So there may be infidelity of the immunophenotype. It may change during treatment. There are certain treatment-related effects. So this alone becomes a slightly risky approach, and it has to be again integrated with the different from normal maturation, which is a much more robust approach. But in which again the expertise and proper validation is very important. So here what is done is that first the validation of the study is performed with a spectrum of normal and regenerating marrows. And then based on that patient database, the templates are defined that what is the population that is falling in the empty spaces, what we call, or outside of this normal maturational spectrum. So the guidelines recommend that we use a combination of both these approaches. This is just to show what I was mentioning earlier, that during normal maturation, there'll be a spectrum of antigenic differentiation. They will come, they will disappear, from weak, they become strong, again they come down. So for the various antigens, from the early stage to the mature stage, there would be a spectrum, and this is what we use for the DFN approach. We all would be aware of the term hematogoons, which we use for the normal regenerating B lymphoid blasts. So they are categorized into stage 1, 2, 3, and then of course you have the mature B cells. So stage 1 would have CD34 along with bright CD10. I would be showing this in subsequent dot plots along with 19 and 38. Stage 2, the immaturity marker 34 will become negative. CD10 will be moderate positivity, and stage 3, we would get some amount of CD20. Also, you can call it as the naive B cells. And here in the mature B cell, the CD10 would disappear. So there is a certain spectrum that comes. Now here, if we see, type 1 is the pink, type 2 is the blue, type 3 is the violet, and these are the mature B cells. So CD10 versus 34. So the type 1 hematogoons, they are co-positive for CD10 and 34, and CD10 is brightly expressed on the y-axis, we can see. Then we have the type 2, which has become negative for CD34. Then type 3, where again CD10 has come down a little bit, and we see some amount of CD20 expression over here. So type 1, type 2 is showing heterogeneous CD20, and this is type 3 and the mature B cells. Again, CD10 versus 19. Same, we can see the spectrum. So what is important to notice that you are seeing a certain spectrum or a trail in the maturation pattern in the antigens. And CD10 versus 45. Here, CD38 versus 45 again. Now, the same dot plots I would be showing you with the abnormal population. So here you have 1, 2, 3 and mature. But we have one particular population which is very bright for CD10. So it is falling outside our spectrum. So there you have bright CD10 expression. Again, in CD10 versus CD20, it is standing out. CD10 versus 19. And here in the CD10 versus 45, we can see that this population is almost negative for CD45, very dim to negative, even compared to the type 1B hematogoons. So bright CD10 expression, dim to negative CD45. Coming to the sample requirements, it is stressed that the first full bone marrow aspirate should preferably taken for the flow MRD, because we do require a large number of cells. So we require the initial aspirate, as subsequently we can get hemodilution. Then this point has been mentioned by Dr. Sirisha also, that for TALL initially they were saying that yes, we can do it on the peripheral blood, but there the levels would be about a log lower than the bone marrow. For BALL, they can be much lower. So as of now, the recommendation is that we should go in for a bone marrow sample for both BALL and TALL flow MRD. The prerequisites, this is for the pathologists. So important is to collect adequate number of events to identify a small population, then evaluate enough parameters, the antigens or the markers that you're doing. So the recommendation is that minimum it should be a 6-color panel. Of course, now we have 8, 10, 12 colors. Then understand and define the normal patterns of antigen expression during your validation study, and also understand the pattern modifications in actively regenerating versus the resting marrow. The dot plots that I had showed you of the hematogones were of a resting marrow. So when it is actively regenerating, we can get some amount of variation in them also, and we should not constitute that as a MRD. We should be aware of the changes that can be present. Then, is a diagnostic flow sample essential? It is required, it can be helpful, however, it is not essential. So, because we would use it mainly for evaluating the LAIPs. Now, what is the problem with the LAIPs? We do know that, almost all the markers, CD10, 20, 34, and 45, they have been reported to fluctuate with therapy and relapse. And many times the diagnostic phenotype may not even be available. That should not stop you from doing the MRD. The variables to keep in mind. The level of hematogones can be quite high after therapy is stopped. Post-induction, generally not much of a problem. Post-consolidation marrows, yes, you can get a high percentage of hematogones. The distribution of hematogones may shift to the left. So the type 1 versus the type 2 percentage, if you see, the type 1 may expand. And targeted therapy, for example, rituximab. So, the 10, 20 that we were seeing, the heterogeneous expression of 20, that may completely disappear even in the hematogones post-rituximab. So, we need to interpret the dot plots in the appropriate context, and we should be aware of all these variables. There are MRD mimics also that can occur. So, we talk about the MRD by flow technique. The advantages, firstly, of course, it's rapid. So if you compare it to, for example, NGS that takes so many days, flow results can be processed within a few hours. So most important advantage, it is rapid. It has the sensitivity that is required. So as of now, the levels that are guiding the therapy is 10 to the power minus 4, and that sensitivity can be achieved by flow cytometry. And another important thing is that it is applicable to almost all the patients. The disadvantages. The immunophenotypic shifts can occur during treatment, so use of the LAIP alone is risky. I had mentioned that earlier also. The other thing is that it is an interpretative assay, so it's a slightly subjective interpretation. So it requires consistent flow technique, detailed understanding of the antigenic expression, and maturation patterns in normal and regenerating marrow, because it will be slightly operator independent in the sense that the person who's interpreting their experience and expertise in the subject can affect the the analysis. So as of now, it is being looked at that if we can standardize all the other things, can we go in for an automated software, for interpretation? These are things which are being looked at for the future. But if we consider the current scenario, this is one thing which does influence the interpretation. And that is why it is recommended that in addition to your validation, equals participation is very important, because there all the labs, they would be getting a similar sample and the results can be compared. We all may do what we consider a proper validation, but how do we know that whatever we are reporting, whatever we are considering abnormal, is that actually abnormal or not? Coming to the role of MRD in AML, if we compare ALL, MRD and AML, here it is a little more challenging. So that's because obviously AML is a more heterogeneous disease. The blasts are also more heterogeneous. We all are aware of the various differentiations that the blasts can show. So they may not be in that tighter cluster. They may be spread across more of our dot plots. Second is, again, immunophenotypic shifts can occur. So some aberrancy that is there at the time of diagnosis, it may not persist during therapy. On the other hand, new aberrancies can appear. But what is known is that MRD positivity does predict increased risk of relapse. And we are not very sure about the MRD negative over here, however, because improved outcomes don't necessarily require MRD negativity. And sometimes a minority of MRD negative patients will relapse. So the relation is there, but it is currently not as strong as is seen in ALL. Coming to the NCCN guidelines for AML. So they have included the criteria of MRD CR. So a complete remission, they define it whether it is without MRD, that there is negativity for either PCR marker or negativity by flow cytometry MRD. So that has also been included in the criteria now. Then again, so again, they have defined the techniques by which MRD can be evaluated over here. And they do mention that it is not MRD positivity is not proof of relapse. However, a persistent positive result will indicate that there is an increased risk of relapse. The timing again would be upon completion of the initial induction before transplant, and additional time points should be guided by the regimen used. These are the ELN 2021 guidelines. There was mainly they are similar to the guidelines that were released in 2018. There has been some updation. So what they do recommend is that whenever available, a diagnostic sample of flow should also be done for the patient. Then they have recommended harmonization or integration of the LAIP and the DFN, difference from normal strategy, and recommended a few markers that your panel should include these markers: 34, 117, 45, 13, 33, 56, 7, and HLA-DR. Of course, monocytic markers would be separate. They have also specified that particular attention should be devoted to evaluating the expression of the aberrant immunophenotypes in regenerating bone marrow. So we should not just include resting marrows. Regenerating marrows should be included in whatever we are considering our normal maturational spectrum. Now, sometimes when the results are not that clear, we are not sure whether this is an absolute positive MRD or is it due to a stressed marrow. Then a repeat analysis after 2 to 4 weeks is recommended. Again, there is the emphasis on a first full bone marrow aspirate, and this should be processed within 3 days of storage, undiluted, in ambient conditions. Of course, it is recommended that when you are doing your validation, also do the specimen stability studies, whether your specimens are able to give the same results. But as per their guidelines, within 3 days is fine, or 72 hours. Then again, for talking about the number of events, they have kept it quite conservative, that more than at least 5 lakh CD45 positive cells should be taken, and at least 100 viable cells in the blast compartment should be present. And we should, by and large, when we are validating the assay, go for the rare event analysis recommendations that are there in CAP also. So LOD and LOQ should be defined, and they should be mentioned in your report, that what is your lower limit of quantification below which your assay is not that specific. So needless to say, it should be below the cutoff. As of now, the cutoff for AML MRD is taken as 0.1. So whatever number of events you are taking, your LOQ should go down to below that cutoff. Now, another thing which is frequently discussed is the need for quality assurance. Whether it is flow, whether any other technique, it is important that firstly you have your internal quality assurance, that is, your validation is detailed and includes both normal and regenerating marrows, your instrument settings are proper, your internal controls are run. So you should be able to define the MRD positive events as positive. In addition, you should be aware about the mimics or artifacts that can occur, what are the post-therapy related changes, and should have experience with high event analysis and how to differentiate the MRD from the background debris. Hence, it is recommended that you should be participating in an EQUAS scheme. We do have national and international EQUAS. All those are available. Here, the samples would be sent out by your central lab and analyzed by the participant labs. There would be a standardized technique and uniformity and comparability in the reporting of results. So to summarize the current clinical applications of MRD, it is used for the assessment of early response and prognosis, for the risk stratification of patients for therapy intensification or reduction, monitoring of relapse after conventional chemotherapy, monitoring for disease status pre and post-transplant. Dr. Pooja would be talking about that. And in the era of individualized therapy, MRD is considered the standard of care for ALL. The role of MRD in AML is evolving, but it is definitely a predictor of relapse. Both the ELN and NCCN recommendations include the CR-MRD as response criteria for AML, and it can be done by flow cytometry or PCR depending upon the targets. It was very detailed topic, so I did not include the PCR recommendations and the clinical recommendations. All of them are given over there. But what we are very clear about is that residual disease is strongly associated with poor outcome, whether it is done post-induction, post-consolidation, pre-transplant, or post-transplant. Thank you.
Thank you very much, Dr. Shivali, for such a lucid presentation. We have many queries, so we'll talk about it after Dr. Pooja's presentation. Welcome, Dr. Pooja, and she is an associate consultant in pediatric hematology, oncology, and BMT at Narayan Hridayalaya, Dr. Mazumdar Shaw Center. She will be talking on significance of pre and post stem cell transplantation MRD in pediatric leukemias. Over to you, Dr. Pooja.
Good evening, everyone. Thank you, sir, for the kind introduction, and thank you, Onquest, to give me this chance. I'll share my screen now. I hope my slides are seen.
Yes, yes.
Yes, sir. And it's on the full screen mode.
Right.
Yes, sir. Today, I'll be speaking about the significance of pre and post-transplant MRD in pediatric leukemia. In this webinar, we'll basically focus how this has a prognostic role in transplant. So as we all know, high burden of MRD is negatively correlated with post-transplant survival because the risk of leukemia recurrence as well as non-transplant related mortality also increases with a greater level of MRD. I'll be talking under the following headings. One is MRD prior to transplant, MRD post-transplant. Is there a correlation between the pre and the post HSCT MRD, and what can be done, what intervention can be done based on our MRD? So coming to the pre-transplant MRD. So this is just an interpolation of several studies, and the data has been placed as a graph where you can see as the pre-transplant MRD increases, the cumulative incidence of relapse also increases. Coming to details regarding this, I think Madam already discussed regarding the methods of detection of MRD, and it is still unclear which level of MRD, whether it's analyzed by a PCR method or by NGS or by flow cytometry, whether we can interchange them and correlate them. Now, most of the protocols have been using the flow cytometry like what we are using in India, and European countries and European protocols have been using the real-time quantitative PCR method. The role of NGS, especially prior to transplant and post-transplant, is still in infancy, but there has been a data according to the COG study, which actually shows something very interesting, which says that those patients whose MRD was negative prior to transplant had almost a 0% relapse rate, that too at 2 years, as compared to the same MRD, which was done by a flow cytometry, which was negative, and still there was a 16% chance of a 2-year relapse. showing that it may be more sensitive, but we need to have more studies regarding this method in MRD. Now, coming to the pre-transplant MRD, there are various studies. The first study was done by Nccn et al. In 1990, as early as 1990, which showed that if your MRD was very high positive, as you can see here, the cumulative incidence of relapse was almost 100%. This was, mind you, this was very early, it was in 1990s. But this used a semi-quantitative PCR method. The first real-time PCR method was done by van der Velden, but this was a very small cohort of just 17 patients. We have a bigger cohort of study, which was done by Bader et al. This was the ALL-REZ BFM study protocol, and this was a prospective study. And this kind of showed us that if you had very high level positivity, then there was a higher level of MRD being positive. If the MRD was positive, very high positive prior to transplant, the relapse risk was higher. This was an interesting study which was published in 2018, where they were trying to see the pre and the post-transplant MRD in children. So this graph shows there are two graphs here. One is showing the event-free survival over a period of 10 years and the relapse over the period of 10 years in patients comparing their pre-transplant MRD. And as the graph shows, you can see that if there is a negative MRD prior to transplant, then the event-free survival probability is around 73%, as well as the relapse risk becomes as less as 20%. Whereas if you have a very high positive MRD, then you have the survival rate comes down to 18%, and the relapse rate increases to 73%. This is a big study of 119 patients. The other, this graph, what it shows is if other than the MRD, which we are trying to see pre-transplant, can even the phase, the disease status of the patient also affect this? That means whether the patient was transplanted in a complete remission 1 or a complete remission 2. What was noted is that if your pre-transplant MRD was negative prior to transplant, or it was low positive prior to transplant in CR1, the survival rate was almost similar, 70 to 63%. Whereas if your pre-transplant MRD was high positive in a CR1 patient, the event-free survival was almost 0%. If you compare it with the patient who has come in CR2 and the pre-transplant MRD was negative, then the child's survival rate was around 78%. But in this criteria of, in this category of patients, it did not matter whether you were low positive or high positive. Any positive MRD in a patient who was in CR2 prior to transplant had a dismal prognosis of just having a survival rate of around 24 to 25%. This is a forum trial. This is a clinical trial, which was a randomized, controlled, open-labeled international trial. And this study was recently published in 2021. Why I'm mentioning this study is because whatever we have read through and whatever studies I went through, this is the only trial which says something reverse regarding the pre-transplant MRD and its effect on survival. So this was a big study conducted, and basically it was just to see whether these patients are able to tolerate a TBI-based regimen or a without radiation, that is chemo-based regimen for conditioning. But in that, they did measure the MRD prior to transplant, and what they found is it did not have any effect on the survival. This was quite surprising, and what I could see in the study was majority of the patients had a favorable MRD profile. So because as we know from previous studies, a pre-transplant MRD predicts your survival later. And now we have new treatment methods like immunotherapies, which have come forward. So they have tried their level best to get the pre-transplant MRD to an acceptable level and then transplant the patient. So I guess probably the patient's favorable MRD profile was the reason for this. Coming to post-transplant MRD, we all know the importance of pre-transplant MRD, but post-transplant MRD carries a major role in intervention as well as has a major role in prognosis. There are various studies of the post-transplant MRD, and most of the times they have used the quantitative PCR method, and few centers have used the flow cytometry. What is jarring in this is that if you had an MRD positivity after transplant, within 100 days of transplant, there was a 2.5-fold higher risk of treatment failure. And it was 7.8-fold higher if it was detected after 100 days. That means if you have a post-transplant MRD, which is getting positive on follow-up, that is further from the date of transplant, then the child is in trouble. So this is another graph which is showing, based on the post-HSCT MRD, their event-free survival in the first trimester and third trimester. What they mean by the first trimester, it is done in the first 100 days post-transplant, and third trimester is when they have done it between 6 to 9 months post-transplant. What you can see is that if the MRD, whether it's low positive or high positive, in a patient within the first 100 days of transplant, your survival rate is almost similar. Okay. Whereas if you have a patient which is later in the transplant, between 6 to 9 months, and his MRD is high positive, the survival rate becomes almost 0. The other studies also which have done here, which are mentioned here, is they have tried to compare whether your MRD from the pre-transplant has changed to the post-transplant, and does it make a major difference in the survival. So they had various categories in that. They had patients who were unchanged negative. That means they were negative prior to transplant, and post-transplant also MRD is negative. Then we had unchanged positive. You were positive before, remain positive after transplant also. Then you have decreasing to negative. That is, you have a high positive MRD which has become negative, or you have decreasing to low positive. That is, you have a high MRD before and it has become a low positive. So these, or you have a increasing MRD. That is, a negative has become positive, or a low positive MRD has become high positive. So based on this, they were able to say that if you had a patient in the earlier in transplant, that is again when they have mentioned HSCT1, that is within 100 days, and HSCT3 is between 6 to 9 months. What you can see is, as we go further down the transplant, if your MRD is increasing, as you can see here, your survival rate drastically comes down from here like 23% to around 8%. Whereas if you have a patient who has a decreasing MRD or who has an unchanged negative MRD, you can have a survival rate of around 88 to 100%. So as what I would like to stress is, higher post-transplant MRD levels are associated with higher risk of relapse. And the later the MRD positivity occurrence, the higher the risk of relapse. Hence, not only pre-transplant MRD, a post-transplant serial and tight monitoring of MRD is more predictive of a relapse risk and can guide us in risk-adapted intervention. This was a beautiful study which was published in Blood, and this was an approach where they had 616 patients of ALL from 1 to 21 years. This was an international database, and we had it was a multi-center observational study. And what they did is they divided these patients in 4 groups based on the MRD. So either it was an undetectable MRD or it was an MRD low positive based on whether it was by a PCR method or by the flow cytometry. That is, if I'm talking about Indian standards, we would say if it is less than 0.01%, if it is between 0.01 to less than 0.1%, and MRD high positive, and anything more than 0.1% being MRD very high positive. So what they saw is, if you have a pre-transplant MRD, which is very high positive, your two years cumulative incidence of relapse is around 44%, as compared to a patient who has a negative MRD prior to transplant, where the relapse risk would be as low as 20%. This is another slide which then says that if you're comparing your pre-transplant and your post-transplant levels, the gist of this is, if you have a pre-transplant MRD which is negative in a child or low positive, and post-transplant also the child continues to be low positive or low negative, the child is at a very low risk of relapse. Whereas if you have a pre-transplant MRD which is high, and in post-transplant period, if there is any detectable MRD, the child is going to be at an increased risk of relapse. So this again stresses that probably monitoring and seeing the post-transplant MRD is very, very important rather than just stressing on the pre-transplant MRD. Okay, this is the event-free survival and the overall survival, which is actually trying to say the same thing. But one important thing is, suppose you have a patient who is getting transplanted, and unfortunately the child's pre-transplant level of MRD is very high. But post-transplant, this child's MRD falls down. Then definitely the child's chance of relapse is going to be less and survival risk is going to be better. Okay. What can we do? What are the measures which we can do? What we think post-transplant may help a patient who is MRD positive or negative post-transplant? One important complication which we do see post-transplant is GVHD. What is quite important regarding GVHD in MRD is, suppose you have an MRD positive patient who has no GVHD, then that patient can have a higher relapse risk. Suppose if you have an MRD positive patient with GVHD, suppose he has a positive, this is MRD positive and GVHD is there, then your relapse rate can be as similar to an MRD negative patient with no GVHD. So GVHD does play an important role. And if we have GVHD, it will have an indirect effect of GVL, and it would indirectly help to decrease the risk of relapse. The same study made a prognostic integrated risk scoring system where they took 3 parameters into account. One was the remission status of the patient, whether the child was in CR1, CR2 or more than CR2. And based on that, they gave points. Like you can see the score of 5 for a higher CR. The second would be conditioning regimen. As majority of the times we use a TBI based regimen, and it has been seen that non-TBI based regimen or non-TBI based conditioning has had a higher risk of relapse. So they have given a score of 4. And also the prior to HSCT MRD, whether it is negative, whether it is high or very high. So they have given a score of 7 and 9. And then based on this score, they had divided these patients. So this study was actually between 1999 and 2015. Then they divided their cohort into 2. So they divided half, like from 1999 to 2008 was the validation, the variable set, and the validation set was the next cohort where they applied the score to see whether how useful this was. So based on the score, if your score was good, then definitely your incidence of relapse was less. If the score was poor, you can see that the relapse rate even at 2 years post-transplant is higher. And the same thing, this same score was then applied on the second cohort, and it showed, it validated the same thing, that if you have a good score, you have a lesser chance of relapse. And if you have a poor score, definitely the risk of relapse even at 2 years is higher. Now, this was mainly, majority of the studies have been regarding ALL. Regarding AML also, this was a study which was done by the BFM AML collaborative study, and this was done in 108 pediatric AML patients who had various AML aberrancies. We all know that AML patients are categorized according to the risk stratification is based on cytogenetics, on MRD and many other things. So MRD also played a part. So they saw that those patients whose pre-transplant MRD was positive, their 5-year overall survival was just 57% as compared to 83% in a negative group. So hence the relapse risk was also high. And if your pre-transplant MRD was positive, and then because of certain immunotherapy or because of certain chemotherapy measures which the clinician has taken, there has been a reduction in the MRD. If the reduction in the MRD has been 2 log reduction, then the overall survival has been better to even 78% as compared to one which is less than 2 log, which is around 39%. They also divided the study, again divided their patients based on the MRD as low, intermediate and high, and that is a pre-transplant MRD. And this also proves that if you have a low pre-transplant MRD, your survival can be as high as 83% as compared to someone who is having a high MRD pre-HSCT where the survival is around 39%. Do we have a role of chimerism in this? See, majority of the patients post-transplant, when we try to know whether the child is doing well post-transplant, one of the measures to know is to see the percentage of donor cells in the recipient. So using chimerism alone would be less sensitive, but if coupled along with MRD measurement, it would help. It can have an early way of detecting relapse. This was a study which was published, and they had 163 patients, and they categorized patients as those who had complete chimerism or who had a very low level of mixed chimerism, those who had an increasing mixed chimerism, and those who had a decreasing mixed chimerism. So in the increasing mixed chimerism, which was around 46 patients, they could see that 26, almost 50% of them were experiencing a relapse. And no relapse was reported in those patients who had a decreasing mixed chimerism group. Now, we have talked about pre-transplant and post-transplant MRD. But what do we do when we know that we have a patient who has been pre-transplant positive? Suppose I have a patient who is pre-transplant positive, I would try my best to intensify my treatment, be it with chemotherapy or be it with immunotherapy, to bring the MRD to be negative or to be low positive as it affects the prognosis in future. If post-transplant, we are going to monitor a child and see the MRD, we need to know what has to be done once we get the report of the child. Few of the things which do help is, the best would be to rapidly withdraw immunosuppression. So what would happen is we would try to induce a GVHD, and as we saw in the slides before, GVHD definitely helps to decrease the relapse risk because of the GVL effect. The next would be, despite you withdrawing the immunosuppression, and still if the MRD continues to be positive, then you can even consider something called as donor lymphocyte infusions in these patients. Now we have so many new therapies which have come forward. We have had patients who have relapsed probably 6 to 7 months post-transplant, and now we have immunotherapy which has come through. We have blinatumab and inotuzumab based on the antigen which the cancer cell expresses. We can try these as a bridging therapy for second transplant if required. We also have the chimeric antigen receptor T cell therapy which has come forward, which can be done for these patients post-transplant. So I would like to conclude with the message of MRD measurement, both pre and post HSCT, has been associated with relapse and poor survival. Pre-transplant MRD allows early identification of patients at higher risk of relapse after allogenic transplant. MRD post HSCT is probably more important than pre-HSCT and can detect very high risk patients early. GVHD with the GVL effect reduces the risk of relapse. MRD monitoring can be a very valuable tool to guide individualized treatment decisions. Thank you.
Thank you, Dr. Pooja, for such an excellent presentation. And all the three speakers have many questions. Shall we start with the questions? Question number one is, MRD negative remission means doctors are not detecting cancer cells in the bone marrow or blood, and patients don't have any signs or symptoms of cancer. Maintenance therapy is given to help keep cancer from coming back after it has disappeared following the first therapy. See here, Dr. Banerjee actually wants that we should be very much clear about MRD negative remission and MRD positive. When do we say yes, MRD positive? When do we say MRD negative? If so, MRD negative remission means doctors are not detecting cancer cells in the bone marrow. Yes, Dr. Sirisha, please.
So MRD, in the sense like it depends on the technique what we follow. So when we call MRD negative, you can see the report as less than 0.01. You don't see it as 0.00 something like that. So when you see that it is less than 0.01, that means like it is a negligible disease, and then you are counting in 1 in 10,000 cells and it is not detectable. The chances of relapse are very less. Of course, it has limitations of like, being flow, and then you can go ahead with the PCR technique. Dr. Shivali has already highlighted that, where you can increase the detection, accuracy goes up, and then you can count in 1 in lakh by that method, which we are not doing in India. So, we have to interpret in that way. And Dr. Pooja also has shown in her presentation that, if we take the chemotherapy patients at the end of the induction, at the end of the consolidation, both like if you are less than 0.01 at both time points, then you will be called as low risk, where your chances of relapse are less than 2%. So literature is clear about that.
Right.
But if you are high risk, that is at week 12 or week 9 as per UCAL, if you are more than 0.1, you are very high risk, and then definitely you have to go for HSCT. So in between it is intermediate risk, and then you augment the treatment and then follow the MRD. So according to protocol, there are clear guidelines, I will say. And then it's not that, you are not able to detect the cell, but there is a cutoff for that. So you call it as a specific cutoff for that point where you are doing the test.
Right. Question for Dr. Shivali. How is MRD measured in multiple myeloma?
Yeah, so MRD is playing its role in a lot of diseases, and myeloma is also among them, in which it is recommended in the guidelines. So definitely it can be done by flow, or it can be done by NGS. The cutoff there is much higher. It is 0.001%. And yes, it has been associated with improved progression-free survival and overall. Right. So rest, as the main topic is acute leukemia, we'll stick to that.
Yeah. I think this question has already been answered by Dr. Sirisha. Shall we go to the next question? Yes, question 4 from Dr. Banerjee. Will I need pre-authorization from an insurance provider before the test is done? That is MRD test, if it is done. Do we need a pre-authorization from the insurance company? Anybody?
No.
Okay.
I will say, like, from we have a good number of insurance patients with us who are taking treatment, where we don't take pre-authorization before we do the MRD. At the time of diagnosis itself, we specifically mention what are the what is the treatment protocol and how do we take them forward. In the beginning itself, we brief them. And then doctor over there, I am sure, like, must be aware of little bit of things about like the importance of doing bone marrow test, MRD and all those things. That is why we never got any patient who got rejected because we are doing the MRD at the end of the consolidation or induction. But in the beginning, at times, as many of us would have faced, where insurance company tries to reject the treatment itself. And then we have to get back to them saying that it is not congenital, because all other than congenital conditions they are supposed to cover. So when we speak to them, they do cover it. We have never had any problems in getting the insurance coverage for the MRD testing.
Right. Thank you, Dr. Sirisha. Next question is, will insurance cover MRD testing also?
Yes.
Okay,
Definitely.
fine. Next question. This is same. Then next question. What should be the time gap between MRD and transplant, Dr. Pooja?
So if you're talking about a pre-transplant MRD,
and
most of the studies, yes, sir?
Yes, you're right. What should be the time gap between MRD and transplant?
Yeah, as near to the transplant would be better. Okay. Most of the studies have shown that it is done within 30 days of starting transplant, but the sooner it is closer to the transplant, it is better. Post-transplant, there is MRD detection. No paper or no study will tell you exactly when it has to be done, but majority of the places people have been doing it 3 monthly. So
Okay.
people have been doing at 100 days and then at 6 months and 9 months and then 12 months. Few studies have gone up till 2 years, but majority of the centers would do at least yearly afterwards. Yes.
Right. Thank you, Dr. Pooja. Are there any guidelines? I think you've already answered this question. And then we go to the next question. What is the indication of transplant for a child with intermediate risk AML based on MRD?
So, sorry, sir, can I take up that?
Yes, yes.
Yeah, so based on AML, most of us do, like you divide them into good risk, intermediate risk and high risk. Intermediate risk is where you don't have neither good risk factors or high risk factors in them. Definitely there is a role of MRD in guiding the further treatment. So if you have high risk genetics, always assess them at the end of the first month itself. As we know, like in AML, both first month and second month are induction and then followed by consolidation in third and fourth month are consolidations. So in the high risk genetic cases where we may have to augment the treatment, so in those cases at the end of the first month, we assess if it is more than 1% MRD. As we know, like, in MRD in AML is less than 0.1%, but high risk will be like if it is more than 1% with high risk genetics, definitely that is an indication for transplant. Whereas in intermediate risk, when you assess them at the end of the induction, that is at the end of second month, if the MRD is more than 1%, definitely it is an indication for stem cell transplant.
Right. Thank you, Dr. Sirisha. Why is the bone marrow sample preferable for MRD as compared to peripheral blood? Would you recommend a baseline MRD on a peripheral blood specimen full of blast cells? Or again, should we opt for a bone marrow sample? Dr. Shivali, are you online?
Yeah. So we have mentioned that in the presentation that the bone marrow sample is preferable because there can be a log difference. So in TLL, it has said up till 1 log. In VLL MRD, it may be even 2 to 3 logs lower in the blood. So you may miss a MRD. So that is the reason why, at least at the post-induction, the time points that have been defined, post-induction MRD should be done on the bone marrow. Now, would you recommend a baseline MRD on a peripheral blood sample full of blasts? Probably not. But yes, in the bone marrow, let's say upon morphology, we are getting somewhere between 5 to 15% blasts. I would still recommend a MRD because sometimes in a regenerating marrow, you can get excess normal blasts also. So to differentiate whether those are actively regenerating normal blasts or they are leukemic blasts, we should do MRD. But again, I mean, here you're probably talking of a case of non-response, that the peripheral blood itself is full of blasts, not much room for MRD over there.
Right. Any chance of missing leukemic clone in peripheral blood MRD as compared to bone marrow sample?
Already answered that, sir. Yeah.
Okay. One question, there are no more questions in the chat box. Or I think one question has come up in the question answer. See, Dr. Shivali, which are the monoclonal antibodies we are using for BALN in detecting MRD? And what is the basis?
So the basis is that we should have a backbone of markers. So if we are using multiple tubes, if you are using a single tube, it is fine. If you have more than one tube, you should be able to track your abnormal events from one tube to the other. So you should have certain backbone markers. Most commonly, it's CD45, 19, 10, 34. So those should be present in both your tubes. In addition to that, you can use certain markers which would help you identify the aberrancies. So, CD38 is there, CD58, CD123. It would depend from one panel to the other, CD73. So there are a lot of candidate antibodies. But the primary thing is that you should have backbone markers plus these antibodies that would help you identify the aberrancies.
But are we using CD58, CD73, CD123 in a normal flow cytometric analysis of a leukemic sample? We are not, by and large, we are not using.
Sir, it depends from one institution to the other. So if we are in a hospital setting where we know all our in-house cases are going to come to us for diagnostic flow and for the follow-up MRD, then it makes sense to put that same MRD panel during the diagnosis also. Now, since we are in a referral setting where many of the MRD, in fact, most of the MRD samples that come to us, the diagnostic flow might have been done outside. So for us, it doesn't really make that much of a difference. So we keep our LCD panel different, and the MRD panel has some additional markers.
Okay. Okay. Similarly, say for T lymphocytes and T blasts.
Yes.
At times it becomes very difficult if TDT is negative. It becomes slightly difficult to say what we are actually dealing with. Now, what happens in flow MRD?
So flow MRD, again, so there is a approach.
T cell flow, what I mean is TALL flow.
TALL MRD, what has been observed that these immaturity markers, they can be promiscuous. So TDT does not have much of a role in TALL MRD, because even if it is positive initially, it may become negative later on. So there again, the basic principle would stay the same. We would have multiple tubes. There will be backbone markers. So CD3, cytoplasmic and surface, CD7, CD5, CD48, they would probably be common across the tubes. In addition, we would have some additional markers. CD1656 has to be there to rule out the NK cells. And then it is more of pattern recognition that where would the normal T lymphoid blasts lie and where are these abnormal cells.
Right. One more question has propped up. From diagnostic point of view, which is better mode of diagnosis, flow cytometry or quantitative PCR?
So flow would be primarily for the diagnosis. qPCR would help in the risk stratification.
Okay. I don't think there are any more questions. Yes, there is one. What should be the prognosis if MRD is present in patients with ALL?
So the prognosis becomes poorer.
I don't think there are any more questions. I have a pleasure in welcoming you all, and it is my pleasure to thank all the three speakers for such lovely presentations and making the subject very, very clear and for an interactive session. And I thank Oncos Labs for organizing such a wonderful seminar. Thank you, all of you. Thanks, Oncos. Thank you.
Thank you very much.
Thank you.
Thank you.